patients with intellectual and developmental disabilities. As I'm sure we're all aware, that dental care is a universal challenge for many of our individuals with intellectual and developmental disability. It's not only hard to find people services that are covered by our individual's insurance, but also to find that sensitive care that is so important. I'm pleased to introduce Dr. Ron Kaczynski, DMD, and Dr. Vincent Siasoko to discuss this important topic. Dr. Kaczynski is both a pediatric dentist and an anesthesiologist. He was formerly the chief and program director at the Stephen and Alexandra Cohen Children's Medical Center in New Hyde Park, New York. In 2014, he moved to NYU College of Dentistry, where he assumed the title of Director of Sedation and Anesthesia. In 2018, Dr. Kaczynski became Clinical Director of the Oral Health Center for People with Disabilities, where he has been instrumental in its design and implementation. Dr. Vincent Siasoko is a board-certified family physician and focuses on caring for those with intellectual and developmental disabilities. He's the co-chair of the Cerebral Palsy Associations of New York State Medical Directors Council and co-chair of their annual CP Associations of New York State MD Council. He is the medical director of ADAPT Community Network. He's an assistant professor in the Department of Family and Social Medicine and Department of Pediatrics at the Albert Einstein College of Medicine, and the director of primary care at the Rose F. Kennedy Children's Evaluation and Rehabilitation Center at Montefiore. He also serves as clinical assistant professor at the NYU Grossman School of Medicine. He is an active board member of the American Academy of Developmental Medicine and Dentistry, a clinical director for Special Olympics, and chair of the Special Olympics New York Health Advisory Council. Welcome, doctors. Thanks for coming.
Thank you, Dr. Kansas, for the introductions. So good morning, everybody. Glad you could join us. So you're probably wondering, why is a family physician talking about oral health care so early on a Friday morning? So as you'll see and hear in this presentation, Dr. Kaczynski and I will highlight the importance of interprofessional or interdisciplinary care and how that can effectively be done. Interprofessional care is not only important for our patients' well-being, but also for those students who are training and studying to become healthcare professionals, and those professionals that are already established and just entering our world of developmental disabilities. Next. So just to give an agenda of my piece, I'll give an introduction, give a little broad overview. I'll be talking about interprofessional education, discuss the links between oral health care, primary care, mental and behavioral health care, and discuss some cost savings for treatment of specific conditions. Next. So unfortunately, significant disparities still exist in oral health care between individuals with intellectual or developmental disabilities and the general population. It's been shown that dental care ranks third behind residential and employment opportunities among the most prevalent unmet needs for individuals with intellectual and developmental disabilities. Patients with IDD are at a greater risk for developing dental problems, including dental caries, gingivitis, and other periodontal disease. One study that examined the dental health of individuals with IDD revealed that 33% of the study population had untreated cavities, 80% had gum disease, and 10% were missing teeth. However, it has been noted that improved healthcare collaboration has been cited as a key strategy for healthcare reform. Collaboration in healthcare has been shown to improve patient outcomes, such as reducing preventable adverse drug reactions, decreasing morbidity and mortality rates, and optimizing medication dosages. Teamwork has shown to provide benefits that are pretty obvious, including reducing extra work, increasing job satisfaction, and more importantly, avoiding burnout. Unfortunately, barriers do exist to providing care for the population. So here I broke it down into 4 major categories. So patient-centered barriers. The patients themselves can provide barriers to dentists and providers to take care of them. Patients' anxiety, associated comorbidities, the degree of disability, all of that can provide barriers, unfortunately, depending upon where they live and the support that they have or may not have. Their environment that's out of their control can contribute to the barriers. Transportation has been shown to be a real barrier for an individual's care. Provider-centered barriers as well. So if we have a provider that may not be familiar or have experience with this population, the patient's behavior, the severity of the disease, the extent of the disability will make that provider uncomfortable or not really sure of themselves in terms of how to take care of this population. As Dr. Holder had said in his previous keynote, diagnostic overshadowing is a big issue in our population, where you're treating more of the psychiatric intellectual aspect, but not necessarily the dental or the medical piece. So that can cause problems in itself. It's been shown that 1 out of every 100 medical clinics has a wheelchair scale. Those challenges in itself. Financial barriers, Medicare, Medicaid, we could spend a whole nother conversation about that, about the barriers when it comes to insurances. One of the ongoing barriers has been educational, but to the credit of the dental community, the Commission on Dental Accreditation, as of July 1st, 2020, had required all predoctoral dental hygiene, and dental assistant programs to implement training on how to take care of those with intellectual and developmental disabilities. And they were able to overcome those barriers. So thus, I wanted to focus on the interprofessional education and how we can use that to overcome barriers. Next slide, please. So according to the World Health Organization, interprofessional education occurs when students from 2 or more professions learn about, from, and with each other to enable effective collaboration and improve health outcomes. The Institute of Medicine stated all health professionals should be educated to deliver patient-centered care as members of an interprofessional team, emphasizing evidence-based practice, quality improvement approaches, and informatics. They should work in interdisciplinary teams, cooperate, collaborate, communicate, and integrate care in teams to ensure that care is continuous and reliable. Next slide. So what actually is interprofessional education? So interprofessional education involves educators and learners from 2 or more health professions and their foundational disciplines who jointly create and foster a collaborative learning environment. Aside from that, reflective interactions is really what's key to bring this all together. It's that reflective interaction that helps bridge the distance between thoughts and actions. It helps define problems, consider possible solutions, increasing understanding, and with all of this, making more informed action to improve the quality of care. The goal of interprofessional education is to develop the knowledge, the skills, and attitudes that result in interprofessional team behaviors and competence, to ensure shared decision-making and responsibility for patient care, that team members are empowered to assume leadership on care issues appropriate for their expertise and focus on improving patient outcomes, provision of patient-centered care. So what is not interprofessional education? It is not just myself talking to a dental student and so it's in a 1-hour lecture, then I go home. It's more than that. It needs to involve reflective interaction. It needs to involve accountability and shared responsibility so everybody can benefit from that interaction. Next slide. So why professional education? So when health professionals work effectively as a team, communicate productively, and understand each other's roles, it leads to enhanced quality of patient care, lowered costs, decreased hospital stays, and reduced medical errors. Next slide. So those that learn, and I apologize that the slide got cut off, it's kind of small here. So those that learn through interprofessional education make it easier to connect all the oral, primary care, behavioral, mental health aspects of care to look at the individual as a whole. It makes it easier for me as a family physician to work with Dr. Kaczynski and his group of dentists and other clinicians and other specialists to take care of our individuals. So as you can see, it says the body connection, the mind-body connection. The medical, primary, behavioral, mental health piece really needs to be integrated. It needs to be looked at as a whole. Looking at the brain, neurology, gum disease leads to bacterial infection causing inflammation, making blood more likely to clot, causing strokes. Seizure meds such as Dilantin, Depakote, carbamazepine, phenobarbital, these are medications that we see in our population very frequently, can cause gingival hyperplasia. Phenytoin, carbamazepine can cause alveolar bone loss. From a cardiologic standpoint, gum disease can increase the risk of heart disease by increasing the risk of bacterial infection affecting the heart valves. It's been shown that tooth loss patterns are connected to coronary artery disease. Pulmonology, the lungs, gum disease can contribute to pneumonias and worsen the chronic inflammation in lung disease such as asthma and COPD. Nephrology, those with end-stage renal disease that are going for a transplant actually need a dental clearance before they can even go for that procedure. Endocrinology, periodontal disease is the most common dental disease affecting those with diabetes. Those with diabetes are at a higher risk for gum problems due to poor sugar control. 1 in 5 cases of total tooth loss is linked to diabetes. Osteoporosis puts individuals 3 times at risk to experience tooth loss than those that don't have it. Next slide. So in addition to the primary care, medical, oral health aspect, behavioral mental health is a big component as well, to look at it as a whole, to look at it interprofessionally. 35 to 40% of all individuals with IDD have a diagnosed psychiatric disorder based on some reports. Studies have revealed a strong link between periodontal gum disease, mood conditions like stress, anxiety, and depression. Mental and dental conditions can cause significant changes in mood and behavior, again, leading to unfortunate situations where you have diagnostic overshadowing. Individuals with autism spectrum disorders may grind their teeth, have limited dietary preferences where they may need to be placed on pureed foods. Same thing with patients with cerebral palsy, which can harm teeth. Some may take medications that I mentioned earlier that can exacerbate oral health problems. Anxiety associated with oral health conditions can lead to canker sores, dry mouth, teeth grinding. Again, going back to medications, much like seizure medications, unfortunately, certain psychotropic medications have side effects, causing dry mouth, increased salivation, tardive dyskinesia, dysphagia, oral stomatitis. Other eating disorders such as pica can also affect the health of the teeth. Next slide, please. So when you focus on providing the quality of care, it's sure to follow that the cost will also come down after that. And here's a slide just to kind of give you some ideas of the costs if you're providing quality care. So treating gum disease means lower annual medical costs for diabetes, stroke, heart disease, even those who are pregnant. And treating gum disease reduces hospital admissions for those with diabetes, stroke, and heart disease. So next slide, please. So at this point, I'm going to hand it off to my colleague, Dr. Ron Kaczynski.
Thank you, Vincent. I want to thank Deb and Vincent for inviting me to collaborate and lecture today. My first exposure to Vincent was a couple of years ago, and Vincent and I were able to lecture to our D2 dental students and provide the importance of interprofessional education and how it can be a success. And we actually brought a patient in that we both had treated, Vincent from a medical standpoint as a family physician and myself from a dental perspective. And the patient just elaborated on the importance of how important it was and what a wonderful experience it was for him to have been treated collaboratively. So I think the dental students really benefited from that opportunity. And it just showed the importance of moving forward of the importance of collaborative education. In this slide, which shows what we're talking about here is the importance of, just trying to, sorry about that. What happens to when you have a decrease in episode risk group scores when you have actual treatment of periodontal disease for somebody with diabetes. And it shows the decrease in the episode risk groups, even for diabetes, coronary artery disease, and cerebrovascular disease, when there's intervention from a dental standpoint, both at year 1 and year 2. And it just shows that the dramatic, how medicine and dentistry in collaboration can decrease what's going on. Important to your oral health. If you have children, does your pediatrician assess their oral health? And does your dentist assess your general health? And does your PCP or dentist discuss your diet? And these are all very important questions that I would ask. And unfortunately, in a discussion that I had most recently with a colleague who was very heavily involved in public health and interprofessional education, unfortunately, it doesn't happen as much as we would like it to. And I think the barrier was talked about by Matt Holder initially in his keynote address, and it's financial. And it's unfortunate that our Medicaid and Medicare, the amounts of money, the medical reimbursement model and the dental reimbursement model for us for time is really just not consistent with what we would like it to be. And until that changes, I don't know if we're really going to make strides and advances as we would like to see, as people like Vincent and myself and the people that are here at this meeting today would like to see happen. I think that until legislation occurs and things happen from that standpoint, I don't know if we're going to move as far forward as we want. And I would love to hear other people's comments about that at the end. Here we're looking at the value of what happens when you have quality and cost. What happens when you have outcomes and patient experiences, and what happens when you have interprofessional collaboration. You can see that it really does increase the quality of the medical and dental experience, decreases the costs, and the patient outcomes experience is increased dramatically. Value healthcare benefit here when you have interprofessional collaboration. You see patients have lower costs and better outcomes. Providers have higher patient satisfaction rates and better care efficiencies. The payers have stronger cost controls and reduced risks, and suppliers have alignment with prices with patient outcomes. It's so interesting to look at this slide, because look at all the positives that come out of interprofessional collaboration, and why are we still in the negative? So in looking at this whole model, I wanted to bring in what's an oral healthcare example of what can happen when you have, what happens to today from an oral healthcare perspective. And here's what you see with early childhood caries. And if you look at the before and after, what occurs, and you can see the amount of caries that happens, and the and the treatments outcomes after dental care is provided. Unfortunately, these patients, end up going to the operating room, where it becomes very expensive to be treated, and direct healthcare costs are increased insurmountably. You have, with the early childhood caries, if you have to go to the operating room, you have dental treatment in pre-op, OR, anesthesia, post-op, the dentist, anesthesiologist, the nurse, the dental assistant, all these increase dramatically the healthcare costs. And, early childhood caries, from what causes early childhood caries. And here is, I love this slide. And this is something that we talk about at NYU Dentistry. And what this brings to light is, if we had our collaborative model in place, we could have our pediatricians really educating parents on the importance. If you look at the sugar intake of what goes on, and we have a motto at NYU Dentistry: think before you drink. And if you look at, we have this in almost every clinic, and you look at how much sugar is in, apple juice, in some of the drinks that we have. And you have all these kids today drinking these sport drinks, thinking that they're healthy. If you look at the amount of, and then, obviously up through soda, where one can of soda has 10 teaspoons of sugar in it. tablespoon, sorry. It's so much sugar. And, we have kids drinking these, and I think the drink that gets us the most today are these sports drinks. And, parents advocate for the kids and, drinking them, thinking that they do, get these kids electrolytes back to normal. If you look at the amount of sugar in them, it is insurmountable. Obviously, an ad lib breastfeeding occurs. So if our colleagues in primary care pediatrics, really educated parents from the beginning on the importance of not doing this and not taking, not drinking this kind of, keeping sugar to a minimum in their diet, the importance of what could happen actually from a dental perspective on eliminating early childhood caries. Initially, I remember back when I was at NYU early on, back before I went to LIJ and Cohen Children's Hospital, we were hoping to have caries eliminated by the year 2000. What happened to that? And why haven't we? And that's a major question that I have today. And we've talked about a multitude of things, but what I think it relatively comes down to is sugar intake. And and unfortunately, kids with IDD and on the spectrum and other kids with intellectual and physical disabilities, are rewarded with sugar and candy in schools and their school-based programs. It's unfortunate, and these kids end up the kids who would benefit from not having sugar at all in their diets and end up becoming the kids who have the most amount of caries because of us not doing of our collaborative work together. And I really would we've talked about a vaccination for to eliminate caries. Is that in the future? That would be wonderful. I thought that we might be there by now, but we're certainly not there yet. Again, I think that from a collaborative model, if everybody had this slide in their office, and we showed parents the true problem of what's actually in their diet, maybe we could do a better job of educating parents and providers to eliminate caries, which would ultimately eliminate. If you think about the healthcare costs associated with taking a child to the operating room to take care of teeth, it is clear it's insurmountable. It's preventable. And I think that my biggest message to you guys today is that together we can work in a team approach, and we really can prevent this from occurring. And that would be amazing. This is just one example, and this is what Vincent talked about as well. And treating gum disease in a diabetic population can dramatically decrease ultimate healthcare costs to medicine as well. Well, I'm taking this now from a different perspective, and how do we get to this health delivery transformation is critical. How do we get to System 3.0? And these come from UCLA for healthier children, families, and communities. And this is just looking at it from a little bit of a public health perspective of how are we going to get to this point in time? How do we integrate oral and systemic health? And how do we establish true interprofessional practice? So here we have an ecological model that you're looking at. You can look at, we have in the purple, we're looking at individual patients, caregivers, in the public. Then we have the healthcare providers, and then we have, the health-related organizations, and then globally policies. And then on the sides, we have, research and innovation, clinical decision-making, health informatics systems, patient empowerment, and health and social policies. I just need to change. Okay, so we have, in the individual patients and caregivers in the public, we have knowledge and attitudes towards preventable health behaviors, both oral and systemic, preventative health behaviors, and knowledge and attitude towards interprofessional counseling and team-based care. So that's from that perspective. Then we're looking at social and environmental factors, social economic status, access to hygiene products, and access to healthy foods. Then we have trained systemic integration, trained in IPE, communication, and if we're looking at health from a healthcare provider standpoint, we look at trained, systemic integration, trained IPE providers, communication, teamwork, provider knowledge, time constraints, understanding the value of patient-centered care. And then if we're looking into health-related organizations, we're looking at an EHR, a referral system, IEP, IPE training and curriculum, institutional support for team-based care, and institutional reimbursement and structural support. And then looking at it from a global perspective, this is looking at policy and insurance reimbursement reform, access to care, scope of practice of providers, telehealth, and access for vulnerable populations. So, I mean, if we all look at it from an ecological standpoint, if we all working together, look at where we could come from a true collaborative interprofessional, standpoint. How are we at NYU preparing for this shifting healthcare landscape? Well, we're trying to, NYU is huge. So we're trying to work with NYU Dentistry, the School of Medicine, NYU Steinhardt School of Occupational Therapy, and the Rory Morias College of Nursing. So I was involved in the last couple of years in a program called TOSH, which is really a program whereby we work collaboratively. And it was very hard to do it as we are doing today. I was really hoping for an in-person meeting. It was going to be my first in-person meeting in 2 years. And I think a lot of us were hoping for that. But, and we've done this program now for virtually for the last 2 years, and it doesn't work out as well as it once did. But what we did is we bring in a virtual patient who has typically diabetes and has terrible oral disease, similar to what we talked about before and what Vincent had spoken of. And we have a virtual patient. We bring in a nursing student, a pharmacy student, a dental student, a medical student, and an occupational therapy student. And we try to put them in the same room with this patient. And we have a dental student typically show them how to do an oral exam. And then we have everybody talking about the implications of their perspective, from their perspective specialty, on how to improve things so that to eliminate the dental disease and ultimately minimize medical disease that happens to it. So at NYU, the students are exposed. We're trying to get all the different colleges, within the university to work together from that perspective. And then we have over at Bellevue, we have a true interprofessional education going on, the pediatric dental clinic, along with the primary pediatric clinic, working together as a team to truly integrate medicine and dentistry. We have a rotation in our pediatric dental clinic. We have a nutrition rotation where nutritionists actually and nutrition students work within the dental clinic to talk to students and really do nutritional counseling for students for patients who have severe dental disease. And then we have our dental students, our pediatric residents, go to the maternal health clinic and talk about true interprofessional education. I think even if we could get, my idea and my hopes were in getting us into OBGYN offices and trying to get dentists into OBGYN offices to talk to parents prenatally about the importance of breastfeeding and not falling asleep on the breast, and ultimately not putting kids to bed with the bottle. You would think in the year 2021 that people still wouldn't be doing all of this, and it's unfortunate, but it's still happening. There are parents, kids are still falling asleep on the breast. Early childhood caries is still at its peak. We still have lots of it going on. And kids are still being put to get to bed with bottles. And this is really unfortunate. Bottles of milk or juice. It's still happening on a pretty much a daily basis. And I would love to see that change. Sorry about that. Okay, so our mission. So what's connecting health professionals for better care is the Interprofessional Education Collaborative. And this is, there are organizations here that make this happen, that we have access to, that providers have access to things that are going on. They have models of true professional collaboration. And how do we, I'm not reinventing the wheel, this wheel already exists. So there are places and things for us to find and to truly look towards how to make this happen. IPEC is working in collaboration with academic institutions, will promote, encourage, and support efforts to prepare full health professionals so that they enter the workforce ready for interprofessional collaborative practice that helps to ensure the health of individuals and populations. Their core competencies of IP are values and ethics, roles and responsibilities, interprofessional communication, teams, and teamwork. And this is, again, not reinventing the wheel. This is something that already exists. Looking at values and ethics, we work with individuals and other professions to maintain a climate of mutual respect and shared values. And this is outlined here with sub-competencies, as you can see on the right. I'm not going to go through them. It's all within the PowerPoint that you all have access to. Roles and responsibilities, using the knowledge of one's own role and those of other professions to appropriately assess and address the healthcare needs of patients and to promote and advance the health of populations. Interprofessional communication, communicate with patients, families, communities, and professionals in health and other fields in a responsive and responsible manner that supports a team approach to the promotion and maintenance of health and the prevention and treatment of disease. And teamwork, apply relationship building values and the principles of team dynamics to perform effectively in different team roles to plan, deliver, and evaluate patient population-centered care and population health and programs and policies that are safe, timely, efficient, effective, and equitable. Are these inherent or learned skills? Contributing factors are role modeling, cultural norms. Look at the impact of culture on aviation safety. Aviation seems to be always like the model that we always look towards when we are teaching collaborative education and collaborative models, because it's been going on for so long. Core competencies of IPE, again, are values and ethics, roles and responsibilities, interprofessional communication, teams, and teamwork. So, in our learning objectives within IPE, describe the evolution of U.S. healthcare delivery system, similar to what Matt did this morning. I think he did a wonderful job of doing that. Actually defining what IPE is, as Vincent just did. Understanding the link between oral health, general health, and identify cost savings for treatment of specific oral general health conditions. Identify the benefits, which we did about talking about just as an example of people with diabetes. And I think that the savings of overall general health and if people would if they took care of their nutritional health needs and took care of their dental health, how could it ultimately affect overall general health? Identifying the benefits of value-based healthcare and describing how IPE fits into the evolution of healthcare systems, and describing how IPA and IPP fit in the ecological model of health system change. Application of IPE and IPP to public health principles is health promotion, prevention, disease management, access to care, health equity, social determinants of health, and interprofessionalism. The problem is high prevalence of preventable disease. We need to treat both oral and systemic components of certain chronic conditions. And to improve care provided, a need for oral systemic integration in health profession training, health-related organizations, and policy support. Population is children, older adults, expecting mothers, medically complex and special needs populations, vulnerable populations. I mean, everybody, we're talking about IDD populations today, but I think everybody can benefit from true interprofessional collaboration. What programs are there? Progress, where are we now? IPE is an accreditation requirement for both medicine and dentistry, and state-specific policy changes for IP reimbursement and scope of practice is really what needs to change. And I think as Matt has stated, and I know I saw that wonderful slide of him sitting in the Oval Office, but until our reimbursement model changes and until more money comes into the hands of the providers, are we ever going to get where we really need to be? So I want to thank you all for your time and interest in this wonderful opportunity to speak. It's something that's near and dear to my heart. I can say that I feel very lucky to speak on this topic. I think that being in the largest dental school in the nation and training, 10% of the nation's dentists, it's so important to introduce them to the interprofessional collaboration model and the importance of medicine and dentistry speaking to each other. And I think that the benefits far outweigh the risks. And I hope that in my lifetime that I see this growing and changing and becoming something that is commonplace rather than something that's not, that it doesn't happen on a routine basis. So thank you.
Thank you very much, Dr. Kaczynski. If there are any questions for either Dr. Siasoko or Dr. Kaczynski, if you'd please put them in the chat. We have plenty of time for questions. While we're waiting for that, I would just throw in there that, we've certainly experienced in our dental practice, the amount of staff that is required to perform basic service for many of our individuals is not nearly covered by the reimbursement for routine cleaning. And this is a real barrier for us as far as attracting additional providers and dental hygiene. We rely extensively on fundraising and grants to support that a much needed service. I think that's true across the services that most of us provide. So I'm not seeing any questions come through. We do have some time before our next speaker is due. We have till 11:10. So you guys sped right through. Do you have any additional comments that you'd like to share or that you had to cut? The one question we had that was actually I started was that poster that you shared, I think would be great. This is a discussion that we often have in primary care, sometimes becomes very embedded in practice by the time patients are older and already have significant caries, where sugar is used for enticement of good behavior, to prevent bad behavior, to perform many aspects of basic care. And I think it's an education piece that's missing not only in our medical providers, but for our parents at an early age. So if you could share that poster, I think it would be great for everybody to access.
No, I'd be happy to. I think you're hitting on the most important aspect of what happens, why the IDD population has a prevalence of dental disease. And unfortunately, in an effort to control behaviors and to entice patients to or students to have good behavior, sugar is often used as a reward. And it happens across the board, and it's still happening. And I would love to be able to get that poster into every school-based program that's offered, so that people could honestly see. And the biggest, I think, as I said when I was speaking, the biggest problem I see is those sports drinks, because people think that they're so healthy and good for kids, and kids just have them, they're drinking them all the time, and there's so much sugar in them, and it's a major problem.
We do have a few questions now. One is a comment. Love the idea of including dental education at OBGYN appointments. I think prenatally, that's a great place to intervene. There are some questions about desensitization programs and any tips for providing better mouth care for people who may be very resistant to that.
So for desensitization, there are a lot of patients who benefit from coming in more frequently and trying to, we have in our oral health center is what we call a multi-sensory room. And that room is provided in that it has no dental chair in it. It is a quiet environment with low light, a bubble machine, weighted health blankets and things like that. And it really helps to, if we have to do an oral exam in there, we do that in there. And then ultimately we get that patient into a dental chair, by increasing the number of visits. And if we have to bring them in 4 or 5 times to ultimately get them into the chair, if the parent or provider or whoever they're coming with or caretaker is willing to do that, then we will take up to 6 visits to finally get a patient into a dental chair where we're actually get them to open their mouths and to do some treatment. So desensitization works. Unfortunately, we're not reimbursed for that. So that's again a problem from the reimbursement model. You were spending all this time, which we're willing to do from an in an educational institution, but in private practice model, it becomes a challenge. So that's an issue. But the benefits of desensitization are clearly there.
Also, if I can add too, from the primary care perspective, I think it's always important to communicate and coordinate between different disciplines. So what would work for me for this patient to get them in my exam table to do a full physical exam, I would probably share that with Dr. Kaczynski, so he has an idea of how to approach and address the patient and their fears and their anxieties. So I think desensitization is great, and what they offer at NYU is wonderful. So I think that more of that needs to be done, and also make the families aware of and the caregivers aware that that's available too.
One comment or question earlier was, any tips for providing mouth care for staff?
There's a lot of different models out there on trying to, there's a new toothbrush that out there, or tooth called Willow, and I would love. I'm sorry I didn't have this in the thinking about that today, but it was made in France and it's just being introduced to the U.S. marketplace. And what it is it's basically a robotic toothbrush. And it's trays that you insert into a patient's mouth, and it has bristles that run automatically, and it has a liquid dentifrice that's expired through the bristles in the mouthpiece. So essentially, all the healthcare provider has to do, or the home care provider has to do, is put the tray in the mouth and turn the machine on. Initially, I think it's the next best thing to for the special needs community. I endorse the product. I just recently filmed an endorsement for them, but they're going into the pediatric community, looking at it as like a robotic toothbrush. I find that it will benefit the IDD population tremendously. It's really an amazing product. Anything you can do to entice a kid or a patient to not just a pediatric patient, but anybody to get them to brush their teeth. Again, desensitization. The problem is that the community of people are, COVID, it became even more of a problem with getting it. People didn't want to get into people's mouths and get in there and brush their teeth. So from that perspective, it's another barrier that we had with the pandemic. So, trying to get people in there to actually, your providers in there to actually get in there with a toothbrush is a challenge at best, and especially with some of these kids on the spectrum. It's very hard because they have intraorally, they have the sensory needs and do not want people in their mouths at all. It's a major challenge.
Thank you. On another question, setting aside use of high sugar content reinforcers and their impact on dental oral health, can you comment on relationships between GERD and dental oral health, use of neuroleptics and psychotropics, and dental and oral health, and other interactions for which we should monitor?
Vincent, you want to start with that one, and I'll.
Sure. So, unfortunately, the relationships between GERD with the acidity on the tooth enamel, that's something to be very concerning about. The medications, as I mentioned in my piece, in regards to the dry mouth, the increased salivation, there's a lot of side effects, adverse effects with all of the medications and the conditions that I'm taking care of on my end. So I think that's why it's very important to coordinate with your dental provider as well as the mental health provider to make sure that everybody's aware of what's happening. Also, if there's any changes in medications, be it the dosage, a type of medication, I think it's very important for everybody to know of what's happening. What I find is that, unfortunately, the EHRs don't communicate with each other. So even if you're in the same building, the dental EHR is different than the primary care provider's EHR. So medication lists aren't always transferred that easily. So I think it's very important to make sure everybody is aware. We're all part of a team to make sure that everybody's aware of what medications they're on and any changes. As Dr. Powell had mentioned earlier in his presentation, GERD is commonly seen in this population. So we always have to be made aware of this, the side effects of that. Even though they're being treated for it, it could still affect the oral health care of the individuals.
Dr. Kaczynski, the name of the toothbrush that you mentioned was Willow, is that correct?
Willow, Willo. I'm just looking at it on the internet now. Uh-oh.
And then there's a question, is that the auto brush that I keep seeing advertised on Instagram?
Yes, it's a tray-based system whereby you basically it's in a unit, in a one box unit. It has a liquid dentifrice, different tray types based upon size, and you just insert the trays, turn it on, and the bristles, it exfoliates. I mean, expires the liquid dentifrice into the trays, and it automatically brushes your teeth.
Question again about Willow. Is there any specific population that it would be contraindicated in using? And is there an age limit?
There is not. We were testing it on dementia patients actually in the oral health center because they were the Willow was trying to test market it on different patient populations. I will say the dementia patients were more resistant than the pediatric patients. And what we found is the pediatric patients think it's cool because it's, like a robot. So it's like looking at, really taking it to the Jetsons level, if you will. And obviously and so from that perspective, kids find it, they think it's the cool toothbrush out there. We get over a little bit more difficult and more of a challenge with dementia patients. I did not find a very good level of acceptance.
Okay. In your experience, do patients with IDD tolerate the Willow or similar devices due to its size and difficulty getting it in and out of the mouth?
I've had the most success with IDD population with this toothbrush than any other toothbrush I've ever tried. Again, even the IDD population, think of it as being cool, and it's although those against those with acute severe sensory disorders who have oral sensory disorders, it's still an issue, and that is something that it's hard pressed to address.
Do you have any idea what kind of cost that is?
Yeah, I think that they're selling it for. They're selling it through Instagram to providers they're giving them incentives, and I think it's relatively inexpensive. Not inexpensive, but I think that they're selling it for under $100, and it comes with enough trays for 4 people to be using it, so families can use it together as well. It's definitely something worth looking into from my medical colleagues.
And is that used with typical toothpaste, or is that something else?
It's a liquid dentifrice that comes up with it, and I just saw that in the chat. It comes for $199, but I know there are incentives to providers to get less. I know that Willow will work with institutions to help support them on some level to try to get it into the institution. So it comes, and there's an automatic, similar to some of the other market shares out there. There's automatic reimbursements that will come. The dentifrice comes automatically, will be shipped automatically to the home.
Are there contraindications for the use of this device relating to people with dysphagia and aspiration risk?
The amount of dentifrice, that's a great question, but the amount of liquid dentifrice that's expired into the bristles is not all that much, and there's a suction unit that goes along with it that takes it out of the mouth as well. So I think it's worth looking into for patients with not severe dysphagia, but with mild to moderate dysphagia. I think it may be something that could be beneficial.
Thank you.
Thank you.
So I think that is all our questions.